nerve and its disorder. Okay, facial nerve. The anatomy in short, the course of facial nerve is divided into 5 segments. One is intracranial, other is intracanalicular. Some say it is the three segment intracranial, intertemporal and extratemporal. But it is divided into 5 segments. Intracranial, it is stretches 24 millimeter from the pons to the porus of the internal auditory canal. So facial nerve is the mixed type of nerve which comprise of the motor, neuron and special sensory. Okay, motor, sensory and special sensory, which is the taste sensation. Right? So intracranial segment stretches 24 millimeter from the pons to the porus of the internal auditory canal. It starts from the pons at the level of the floor of the fourth ventricle. The facial nerve starts from the floor of the fourth ventricle, from the pons to the porus of the internal auditory canal. First segment, intracranial segment, 24 millimeter. The intracanal, other is the intracanalicular segment, which the segment which traverses the internal auditory canal. At fundus of the internal auditory canal, it occupies the anterior superior quadrant, where it is joined by the nervus intermedius. Nervus intermedius is the sensory part of the facial nerve. So initially there is a separate nerve fibers. One is motor and other is sensory. Sensory nerve is known as the nervus intermedius. In the internal auditory canal, the nervus intermedius run as a separate nerve between the facial nerve and superior vestibular nerve. So in the internal auditory canal, the intermedius lies between the facial nerve and superior vestibular nerve. The nervus intermedius, also known as the nerve of Wisberg, MCQ aउने question here, carries the taste secretory fiber of the fibers of the facial nerve. So it is the special secretory fibers. It carries the taste sensation. The third part is the labyrinth part. It is also known as the intertemporal part. The labyrinth part is the shortest segment, run for the 4 millimeter length of the labyrinthine part is the 4 millimeter. It starts from beginning of fallopian canal to the geniculate ganglion. So fallopian canal has numerous gaps or dehiscent which render the facial nerve liable to injury. So there is a multiple dehiscent, small dehiscents are there in the fallopian canal. Fallopian canal is the bony canal which houses the facial canal. Right? So fallopian canal is the bony canal which houses the facial nerve, and it have the multiple dehiscents, so that the facial nerve is liable to injury during the mastoid surgery. The other part is the tympanic part. The tympanic segment is the 13 millimeter long and course in the medial wall of the tympanic cavity. अब इसमें पनि MCQ आयो. The length पनि MCQ आयो and the medial wall. Which wall of the tympanic cavity? It is the medial wall of the tympanic cavity. The tympanic segment lies. The tympanic segment over the oval window is the most likely site for the dehiscent. So most common site for the dehiscence of the fallopian canal is the tympanic segment of the facial nerve. Either or MCQ. The mastoid segment span around 20 millimeter distance from the second genu to the stylomastoid foramen until the facial nerve arises out from the stylomastoid foramen. The mastoid segment around 20 millimeter distance. It emerged at the level of digastric muscle through the stylomastoid foramen. So it come out from the stylomastoid foramen. Now the main trunk divide at the pes ancisionus intraparotid plexus of the seventh nerve into the upper temporal facial and lower cervical facial division. So after coming out from the mastoid foramen, the facial nerve divide into the two branches, upper temporal facial and lower cervicofacial branch. But before it enters into the gland, it gives up the 3 branches. It comes out from the temporal bone and it divides into 2 main branches, and before dividing into the 2 main branches in the parotid, it gives the 3 branches: posterior auricular, posterior digastric, and stylohyoid muscle. Aita posterior auricular branch, posterior nerve to posterior digastric, and nerve to stylohyoid muscle. So there are 3 intertemporal branches of the facial nerve. In the tympanic cavity, in the temporal bone, the facial nerve divide into the give rise to a greater petrosal nerve. Greater petrosal nerve arise from the anterior aspect of the geniculate ganglion and emerge on the floor of the middle cranial fossa via the facial hiatus. So it originates in the tympanic cavity, and nerve to stapedius muscle. It arises from the mastoid segment of the facial nerve near the pyramidal eminence, and chorda tympani, it is the sensory supply to the tongue, and it arises in the intertemporal region. In the temporal bone, the nervous innervation lies within the facial nerve. In the temporal bone, the motor branch of the facial nerve and the sensory fibers of the facial nerve, they combine in the totally combine in the facial nerve. So nervus intermedius is incorporated into the motor fiber of the facial nerve. So they are one nerve in the intertemporal bone. Right? त्यो भन्दा अगाडि चाहिँ नि nervus intermedius and facial nerve motor branch चाहिँ नि separate हुन्छ. So blood supply of the facial nerve, there are different blood supply in different segment of the facial nerve. It is medial cerebral artery supplying the motor cortex in the pons. Facial canal, facial nucleus is in the pons is supplied by anterior inferior cerebral artery in the pons. And facial nerve proper is then supplied by anterior inferior cerebral artery, the middle meningeal artery, and the stylomastoid branch of the posterior auricular artery. So it is firstly supplied by anterior inferior cerebral artery, anterior middle meningeal artery, and the posterior auricular artery. So cause of facial nerve. Now come to the, if there is a paralysis of the facial nerve, that is known as the facial palsy. The causes are different from the birth. It may be birth molding, it may be present in the forceps delivery when the child is delivered through the forceps, trauma, basal skull trauma, penetrating injury to the middle ear. If there is trauma to the base of skull, fracture. If there is penetrating injury to the middle ear, like any RTA, road traffic accident, or any penetrating injury, or altitude paralysis, scuba diving, they may cause the facial palsy, but in rare instances. Other neurological causes are opercular syndrome, which is the cortical lesion in the facial motor area. They are rare. Miller-Gubler syndrome, it is the abducens palsy with the contralateral hemiplegia due to lesion in the base of the pons involving the corticospinal tract. So common causes and थाहा पाइरहने याद गरिरहने. So birth मा चाहिँ नि अल्डिङ हुन सक्छ, फेसियल forceps delivery हुन सक्छ, trauma basal skull trauma, fracture, penetrating injury to the middle ear, neurological ma, these are the syndrome which causes the facial palsy. Otherwise, we are interested in mastoiditis. Mastoiditis also leads to the facial nerve, especially the chronic suppurative otitis media, aticoantral, chickenpox, herpes zoster, encephalitis, poliomyelitis, mumps, infectious mononucleosis, leprosy, malaria, almost all this may cause the facial palsy. What are the cause of facial palsy? Leprosy, malaria, syphilis, most important causes like ENT mastoidectomy, herpes zoster oticus, बर्थ भन्यो भने अब स्पेशली एन्सर गऱ्यो भने राम्रो एन्सर गऱ्यो भने चाहिँ यु क्यान डिभाइड बाई बर्थ, ट्रमा, न्युरोलोजिकल, इन्फेक्सन, मेटाबोलिक भनेर। अथवा अब एकैचोटि वाट आर द कज अफ फेसियल पाल्सी भन्यो भने लेप्रोसी, मलेरिया भन्यो भने दे आर द रेयर कज। फर्स्ट कज आर मास्टोइडाइटिस, हर्पेस जोस्टर ओटिकस, चिकन पक्स है त। अनि मेटाबोलिक डिजिज दिस डायबिटिक मेलाइटस, हाइपरटेन्सन, प्रेग्नेन्सी हैन, हाइपरथाइरोइडिज्म, एक्यूट पोर्फायरिया मे कज द facial nerve palsy. These are the cause of the facial nerve palsy. Other cause, cholesteatoma, seventh nerve tumor. If the facial nerve patient develop the facial nerve tumor, glomus jugulare tumor, है ना, leukemia, meningioma, hemangioblastoma, and all the other which you can find in the books. Toxic thalidomide, tetanus, diphtheria, and carbon monoxide poisoning may cause the facial nerve palsy. Parotid surgery, iatrogenic. When we do the surgery, we can injure the facial nerve. It is parotid surgery and the mastoid surgery. Most common surgery, the mastoid surgery and the parotid surgery, where the facial nerve can be damaged. Either. So idiopathic and other cause is the idiopathic. Idiopathic most common cause for the facial nerve palsy is the Bell's palsy, where the cause is unknown. Other is the Mekerson-Rosenthal syndrome. It is the less common, but it is the idiopathic cause for the facial nerve palsy. These are the other causes of the idiopathic causes of the facial nerve palsy. Now the neurophysiology of the nerve. When there is a nerve injury, what will happen? There may be neuropraxia when there is a blockage of transmission of nerve impulse. There is no anatomical defect in the nerve, but there is a transmission of nerve impulse due to the pressure on the nerve. If there is a pressure, excessive pressure from the outside, there is a blockage of the nerve impulse. And it is a rapid and complete recovery of the function with no residual dysfunction or no distal Wallerian degeneration. So there is no Wallerian degeneration, and once the pressure is removed, the neuron will automatically come to the complete recovery. One is neuroplexia. This classification done by the Seddon's classification in 1943. And neuroplexia, first is the neuroplexia. Second is the axonotomesis, and third one the neurotomesis. Axonotomesis, there is a sectioning of the axon or the sufficient pressure to block the exoplasmic flow. So there is a distal Wallerian degeneration occur. And neurotomesis, there is total nerve transection, mixture of the different type of injury, and Wallerian degeneration occur 3 to 4 days following the injury. So there is a complete Wallerian degeneration. Other classification is a Sunderland's classification. It is divided into 5 grades. First one is neuropraxia. Second, third, fourth is the axonomesis, and the fifth one is the neurotomesis. So this is the first degree ma complete recovery huncha, second ma satisfactory recovery huncha, 3 to 4 incomplete, fifth ma weak recovery, and sixth there is this recovery is the other Houseman-Brakeman classification bhancha. त्यो चाहिँ seventh ma चाहिँ there will be no recovery of the, sixth ma चाहिँ there is no recovery of the facial nerve palsy. So these are the altered function of the facial nerve following the injury. What will happen to the facial nerve once it is injured? There may be synkinesis, abnormal synchronization of the movement occur with the voluntary or reflex activity of the muscle that normally do not contract together. So one group of other group of muscle will be activated, or other reflex activity of the will be stimulated, which is not related normally, like crocodile tear. There is an increased unilateral lacrimeation while eating. So the fiber, gustatory fiber is going into the lacrimation. Syn kinase, there is a connection between the lacrimation and the gustatory gland. Oh, so secretory fiber of the submandibular salivary gland is related to the lacrimation. So there is a crocodile tear. While eating, there is a lacrimation. Right? Stapedius tendon contraction, fullness or roaring in the ear with the facial nerve. Some will get the, if there is a faulty connection between the facial nerve and the nerve ending and the muscle, then the stapedius tendon is also contracted. So there will be, if there is a contraction of the stapedius tendon, there will be roaring, or there is a roaring movement of the stapedius muscle, which causes the roaring movement in the ear due to the facial movement. And facial movement हुँदाखेरि चाहिँ stapedius muscle पनि contraction हुन्छ, and that causes the roaring sound in the ear. Facial myokymia, continuous fine fibrillary or undulating movement of the facial muscle. There is a fine movement in the facial muscle. Now, how to evaluate? History taking. So you should take the history. Progressive palsy over the period of 3 weeks, or incomplete palsy that does not start to recover after 3 to 6 weeks, there may be neoplasm. If it is complete, and if it is long standing, it is gradual progressive, there may be neoplasm. And unilateral recurrent palsy, basically it is due to the Bell's palsy, and other is the Mackensen-Rosenthal syndrome, or maybe tumor. Alternating recurrent palsy, there may be Bell's palsy or the Mackensen-Rosenthal syndrome. In bilateral concurrent palsy, systemic disease are related, just like Guillain-Barré syndrome. Most common in the Guillain-Barré syndrome, which causes the bilateral concurrent palsy, leukemia, sarcoidosis. These are the other causes. Like trauma, if there is a head trauma to the both the ear, drug, isoniazid, immunization, influenza, rabies, polio, and bilateral facial palsy with uveitis seen in the sarcoidosis. So you have to take the history, how it is started, how it is progressed. It is unilateral or bilateral, or it is continuous or alternative, so you can differentiate the causes. So careful history preceded by viral prodrome. If there is a facial palsy, and prior to that, if there is a upper respiratory tract infection, viral fever, and fever with coryza and URTI feature, then maybe it may be viral origin. Facial numbness, epiphora, pain, these are the symptoms of the virus, and viral. And physical examination, whether complete head neck examination is pure tone, speech discrimination, reflexes or tympanometry to rule out the any local causes. CT or MRI with a gadolinium will show the enhancement of the labyrinth portion of the nerve if there is any tumor. Topodiagnostic test, electrodiagnostic test. So topodiagnostic tests are the Siemens test. Siemens test ma ke garchhau hamle? We place a paper in the bilateral eye, and then we see the epiphora, excessive lacrimation. If there is a decreased lacrimation, then there may be chance that facial nerve is damaged above the geniculate ganglion. त्यस्तै geniculate ganglion ठीक छ, त्यो भन्दा तल stapedius muscle injury छ भने reflex आउँदैन, acoustic reflex tympanogram मा देखिन्छ. If acoustic reflex is absent but the lacrimation is normal, then there may be transaction of nerve at the level of the above the branch to the stapedius muscle, and if the other is the if the coda tympani nerve is above the coda tympani, third one above the coda tympani nerve, if there is injury to the above the coda tympani nerve, the taste will be absent. Oh, but stapedius muscle normal, and if there is a transaction of the in the parotid region, so only facial nerve of the face motor supply will go, other will be present. Right? So you can make a diagnosis while taking the examining history or the examination where there is a injury to the facial nerve. The specific disease which causes the facial nerve paralysis. Most common cause is the Harpage-Zoster. Most common cause is the Bell's palsy, idiopathic, and this is the Harpage-Zoster oticus, which is known as the Ramsay-Hunt syndrome. Is the second most common cause of the facial paralysis. It comprises 3 to 12% of the facial paralysis in adult and 5% in the children. It is due to the reactivation of the Harpage-Zoster virus in the geniculate ganglion. So there is a Harpage-Zoster virus residing in the geniculate ganglion, which is reactivated following the decrease in the immunity. Right? And there is a viral prodrome followed by severe otalgia. So there is a viral syndrome like tract infection, URTI, severe otalgia, vesicles appear in the external canal or on the auricle, around the auricle. Facial paralysis, rapidly progressive, it appears late but rapidly progressive. There will be sensorineural hearing loss or vestibular dysfunction. Sometimes the patient may complain there is a difficulty in balance system. So there may be cranial nerve, 5 trigeminal nerve, glossopharyngeal, or the 12 nerve may be involved, and PCR is the early diagnosis. So this is the picture of the Harpage-Zoster oticus, Ramsay-Hunt syndrome. There is a vesicles in the ear, in the external auditory canal, and there will be facial nerve palsy in that side. Right? So it is a much poorer prognosis other than the other type of the facial nerve paralysis. There may be persistent weakness in 30 to 50% of the cases. The facial nerve palsy will be remain there in 50% of the up to the 50% of the cases, and only 10% recovers completely. So there is a chance of complete recovery is only 10%. And early treatment with antiviral and steroid is the choice of drug. IV acyclovir or oral vanciclovir can be given. Duration of the therapy may be longer, 2 to 3 weeks, up to 2 to 3 weeks. Bacterial superinfection of vesicle, if there is a post discharge in the vesicles, so we have to give the oral antibiotic, and surgical decompression is not recommended. So surgery not done in the Harpage-Zoster because of so other is Mackerson-Rosenthal syndrome. It is named after the Ernest Mackerson and Kurt Rosenthal. The peculiarity के हुन्छ भने यसमा triad हुन्छ recurrent orofacial edema. Patient gives the history of the repeated orofacial edema, recurrent facial nerve palsy 50 to 90% in cases, and facial nerve palsy is like alternating. एकातिर एउटा हुन्छ, अर्कोतिर फेरि अर्को दिन अर्कोतिर हुन्छ, अर्कोचोटि अर्कोतिर हुन्छ. So there is a recurrent alternative facial palsy, and there is a lingua plicata, fissured tongue in 25% of the cases. So these are the triad of the Michelson-Rosenthal syndromes. कहिलेकाहीँ MCQ मा सोध्छ यो. The most common cause of the facial nerve palsy is the Bell's palsy. It is named after the Charles Bell, हैन? And he called respiratory nerve of the face. Facial nerve like उहाँले चाहिँ respiratory nerve of the face. That controls how the facial expression, and it is the Bell's palsy, idiopathic facial paralysis, and idiopathic facial paralysis. It is the diagnosis of the exclusion. We have to rule out the other causes of the facial nerve palsy. If there is a, we have to rule out there is a no trauma, no tumor, all the other causes, no infective causes. After ruling out all the causes, this is the diagnosis of the exclusion. And most common diagnosis, it is the most common cause for the acute facial palsy. It occurs in 20 to 32.7 per 1 lakh. And Antonio 90 said acute infectious polyneuritis cerebritis acoustofacialis of this for this condition. So there is a peripheral facial neuropathy. You know it is a peripheral facial neuropathy. What difference with the central machani? There will be facial frowning, both side ma present huncha. Facial peripheral central cause bhayo bhance ni the forehead is spared, If the forehead is not spared, it is the peripheral or it is the peripheral facial neuropathy, and it is the unilateral. Both sides are involved equally, and in 1% of the cases there may be bilateral. It is rapid onset within 48 hours. Age is 15 to 45 age group. Male and female both are equally affected, but women of the less than 20 years and men of more than 40 years are more affected. In pregnancy, diabetic, the rate will be increased. Pregnant woman ma diabetic ma chani the incidence will there is also, and familial incidence is more than 4%. So there is a criteria to call it as a idiopathic or Bell's palsy. One is paralysis or paresthesia of all the muscle group on one side of the face. So there is a one side of the muscle of the face is all paralyzed. Hello? So one side of the whole muscle is all paralyzed. There is a sudden onset, absence of sign of the CNS disease, and absence of a sign of the ear or CP angle disease. So there should be no central nervous system disease, there should be no ear disease, there should be no CP angle tumor, or there should be no CP angle any other disease, and the facial paralysis or paresthesia of the muscle of one side of the face should have gone. If the frontal muscle, frontal frowning is present, then that is not Bell's palsy. Bell's palsy ma lower motor type ko huncha. Lower motor type ma chani all the face, all the muscle of the face will, there will be paresis of all the muscle of the face. Pathophysiology, मैले भने idiopathy को exact etiology unknown. It may be viral inflammatory response that induces the edema within the facial nerve. If there is edema of the edema in the fallopian canal, then that edema compresses the facial nerve, and that causes the facial nerve paralysis. And these viruses are implicated: human simplex virus 1, 2, herpes zoster virus, Epstein-Barr virus, influenza virus, adenovirus, and Coxsackie virus. These are the thought of the origin in the Bell's palsy. There may be vascular ischemia, which causes there is a necrosis of the nerve segment, and some say it is the autoimmune disorder, and some say it is the hereditary disorder. Bell's palsy ko kura hai ta yo. So most likely site of the lesion is meatal foramen. If there is a blockage of the meatal foramen, there is a obstruction of the nerve there is a obstruction of the nerve impulse in the meatal foramen. So most likely it is the meatal foramen. MCQ ayo. Bell's palsy ma what is the likely site of the lesion? So in Bell's palsy there is a compression, there is a edema, there is a compression of the nerve, which causes the decrease of the nerve palsy. Nerve conduction, which causes the nerve palsy. And it is the why meatal foramen? It is the narrowest portion of the fallopian canal. There is the highest facial nerve fallopian canal ratio. So it means facial nerve and fallopian canal ratio means there is a no space between the facial nerve and the bony canal. So there is a less space. If there is a less space, if there is a edema in the facial nerve, then it will increase the facial nerve and it will compress against the fallopian canal. Fallopian canal is bony canal. Bony ma chani badne hudaina. So there is if there is edema of the facial nerve, so it will compress automatically against the fallopian canal. So there is a vascular supply, there is a vulnerable anastomotic vascular supply, so there is a less vascular supply and that causes the nerve damage. So these are the anatomical point. Electrophysiological point, there is electromagnetic is evidence of the nerve conduction blockage. So there is when we do the electrophysiological test, there is a nerve conduction blockage in the electromyography, and radiologically at that site meatal foramen, MRI gadolinium, there will be enhancement, and pathologically focus of the pathologically reported there is a pathology in the meatal foramen and there is a evidence of the degeneration of the distal to the foramen. So medical management, controversy, eye protection and the steroid. So in short, antiviral acyclovir or vancomycin can be given. In steroid, we have to give the prednisolone 1 mg per kg body weight 5 days followed by 10 days in taper dose. Like acyclovir, we have to start 200 to 400 mg 5 times daily for 10 days. And prednisolone also, if the patient is around 60 years of the age, 60 kg, then we have to give the 60 kg for the 5 days and then we have to taper for the last 10 days. We have to do the physiotherapy, electric stimulation of the paralyzed muscles. So we have to do the physiotherapy by electric stimulation of the paralyzed muscle of the facial supply. So this is the algorithm. Acute paralysis up to 0 to 14 days, we have to give the prednisolone. If more than 14 days, observe, follow up in 6 months. Follow 5 days. If paralysis, we have to do electronystagmography. So atypical Bell's palsy, in condition in which there are characters the typical Bell's palsy and there is no improvement within the 1 year. Facial nerve should be, we have to explore the facial nerve. If it is not improving by 1 year, and we can do if the facial nerve is permanently damaged, we have to do the facial re-innervation, innervated. We will take the nerve from the other side, other nerve from the same side to supply the facial nerve. Other viral causes, Guillain-Barré syndrome, it is the most common cause for the bilateral facial nerve palsy. acute inflammatory demyelinating polyradioneuropathy. It is following 2 to 3 weeks after URI, upper respiratory tract infection. There is a facial paralysis bilateral, and we have to give the supportive treatment. Yo ta neuroma padincha hola timharo. Infectious neuron mononucleosis. It is caused by the Epstein-Barr virus, generalized fever, sore throat, facial paralysis bilateral in 40%. In HIV also there is a local infection of the facial nerve ganglion by the HIV infection. So other most important cause is the traumatic facial paralysis. Trauma to the temporal bone. Trauma to the temporal bone is it may be longitudinal, transverse, or the mixed type. Here you can see the longitudinal type of fracture of the temporal bone. Longitudinal in 70-90% of the cases seen. Longitudinal if the fracture lies along the long axis of the temporal bone or the petrous pyramid. This is the petrous pyramid. If the long axis of the fracture line runs along the long axis of the petrous pyramid, it is a longitudinal fracture. Trauma to temporal and parietal region of the skull. So it involves this is the parietal, this is the temporal, and there will be bleeding, conductive hearing loss, hemotympanum in the ear, and there is a chance of 20 to 25% chance of facial nerve paralysis in the perigeniculate region, delayed and incomplete. So if there is a hematoma in the middle ear, that compresses the facial nerve and that causes the facial nerve palsy if the fallopian canal is dehiscent. Transverse fracture at the right angle to the petrous pyramid. If the fracture line runs through the transverse to the right angle to the petrous pyramid, maybe occipital and frontal trauma. Agadiबाट head injury भयो भने there may be sensorineural or vestibular dysfunction. The patient also may complain of the dizziness, and facial paralysis is seen in the 50% of the cases. So facial paralysis, अर्को MCQ आयो. Facial paralysis seen most commonly in the transverse fracture of the temporal bone. So management in early post-injury, observation and steroid, delayed or incomplete, non-progressive, ठीक हुन्छ. And if the acute complete and incomplete, acute complete paralysis छ भने we have to explore, we have to explore the temporal bone and we have to decompress the facial nerve. Management in the late post-injury, exploration, approaches for the transmastoid or the middle cranial fossa approach, translabyrinthine approach, and we have to decompress the facial nerve. The other cause is the iatrogenic injury. During the middle ear surgery or the mastoid surgery, there is chance of facial nerve injury, and most common site is the distal tympanic segment, including second genu, followed by the mastoid segment. So during in the iatrogenic injury, there may be chance of middle ear or the chance of facial nerve palsy during the middle ear surgery or the mastoid surgery. If the nerve is known to have disrupted, we have to repair. During the surgery, when you are doing the mastoid surgery, we have to lower the facial canal, facial canal lower गर्न पर्ने हुन्छ. Facial lower गर्दाखेरि, if the surgeon certainly know that he injured the facial nerve, at that time the facial nerve should be repaired. If the patient awakens with the facial paralysis, nerve identified intra-op, observe for the few hours, remove the pack, and then we have to re-explore. So if there is a no injury immediately after the post-op, but the patient develops the facial paralysis, say after 24 hours or 48 hours facial paralysis त्यहाँ छ भने operation गरेको, then we have to observe for the few days for hours and remove the pack, and then we have to re-explore. So in incomplete paralysis, we have to give the oral steroid or observe clinically, and if it is progressed to complete, then we have to re-explore, and if it is a delayed palsy after any uneventful surgery, there may be reactivation of the herpes simplex virus or herpes zoster virus, then we have to give the steroid plus acyclovir. During parotid surgery also, we can do the facial nerve monitoring or harmonic scalpel. So these are the two methods nowadays by using which we can avoid the injury to the facial nerve. So केमा हुन्छ मास्टेड सर्जरीमा हुन सक्छ, प्यारोटिड सर्जरीमा हुन्छ, सीपी एंगल ट्यूमर सर्जरीमा हुन सक्छ, हैन, and maxillofacial trauma or the gunshot injury. These are the causes for the extratemporal segment of the facial nerve paralysis. So facial palsy due to the ear infection. So most common cause is the otitis media. Otitis media, it may be acute otitis media or chronic otitis media. So in acute, direct involvement of the infection through the fallopian canal, dehiscence or physio, there may be dehiscent fallopian canal which causes the facial nerve paralysis. And during mastoid exploration or the facial nerve, the facial nerve palsy is most common in the CSM eticoantral, unsafe type of a CSM, chronic otitis media, squamous muscle active mounts. At that time we have to do the mastoid exploration and facial nerve decompression in chronic suppurative otitis media. So other causes, necrotizing otitis externa. The patient is elderly patient, poorly controlled diabetic, begins in external canal, progress to involve the temporal bone, and the organism is most commonly Pseudomonas aeruginosa. So there will be discharge from the ear canal, pus drain from the fallopian. There will be pus drainage, pus from the ear canal, the pus will come and then pus will be drained from there is a pus in the fallopian canal as well. After surgery we have to do the drainage of the fallopian pus. So other causes are the tumor is facial nerve, benign or malignant. So 5% of facial nerve is dysfunction. Facial schwannoma, congenital cholesteatoma, hemangioma, these are the other cause of the facial nerve tumor. So most common intrinsic tumor of the nerve is nerve sheath and the vascular tumor. So it is the facial schwannoma or neuroma, meningioma and hemangioma. These are the tumor which causes the facial nerve palsy. Facial schwannoma, etiology unknown, arise from the nerve sheath anywhere from CP angle to peripheral branches. It most commonly intertemporal, most commonly labyrinthine segment and geniculate ganglion. Most commonly geniculate ganglion. Vestibular schwannoma, most common lesion in internal auditory canal, and so CP angle tumor, CP angle tumor, facial paralysis, unusual manifestation in vestibular schwannoma. This facial paralysis, unusual manifestation signify an advanced stage. So in vestibular schwannoma, if there is a facial nerve palsy, it shows that there is a advanced stage of the vestibular schwannoma. These are the other causes, rare causes. Most common malignant tumor is squamous cell carcinoma in the middle ear, basal cell carcinoma, other malignant neoplasms. So during the surgery, when you repair primary facial nerve repair, facial nerve repair, we have to do the epineurial repair. By layer, we have to do the repair of the facial nerve. In sometimes we have to do the grafting. The grafting, cable grafting means aru nerve ko segment ल्याएर we have to do the grafting of the facial nerve, like greater auricular nerve, most commonly used, sural nerve, ansa hypoglossy, and medial antebrachial cutaneous nerve. These are the nerve where we can take the graft and we can reposition graft to the facial nerve. Right? Thank you. Any question?